Golfers and tennis elbow are by far and away the most common elbow complaints that I see in my clinic. In today's video, we're going to talk all about them, so let's dive in right now. And welcome back, everybody, to the Building Lifelong Athletes podcast. Thanks so much for stopping by. I really appreciate it. For those who don't know me, my name is Jordan Rennicke, and I'm a dual board certified physician in family and sports medicine. And the goal of this podcast is to help keep you active and healthy for life through actionable, evidence-informed education. Today, we're talking all about epicondylopathy or tennis elbow and golfer's elbow, kind of combining two things at once. So let's dive in right now. So first things first, let's start with some terminology, right? So these are two conditions. They're both very similar, just on opposite sides of the elbow, right? So the old term used to be epicondylitis. You'd see your medial or lateral epicondylitis. That's not what's necessarily what we're using anymore. Sometimes you'll hear terms like tennis elbow for the lateral epicondyle and golfer's elbow for the medial. Those are used and those are fine. Those are actually in the academic literature. I was listening to some podcasts the other day, people talking about, they say they actually prefer tennis elbow because it's just easy and people get it and they know that. That's exactly what they're talking about. So tennis elbow on the lateral side is accepted, golfer's elbow medial. Epicondylitis is kind of going out of favor. Some newer terms now are more like epicondylalgia or epicondylopathy, which, you know, if you just want to make it very hard to say those words, that's it. That's why I think tennis elbow, golfer's elbow, those work fine. But we've gone from that itis to kind of epicondylalgia or apathy, just kind of semantics there, but I just want to talk about it. From an anatomy perspective, let's talk about the anatomy. In the elbow, there's three major bones we talk about, right? The humerus, ulna, and the radius are kind of all at the elbow. The epicondyles are of the humerus, so the distal part of the humerus, and the medial and lateral epicondyles are what we're talking about in these conditions. And we'll talk more about those in a second. On the video here, I'm going to show the anatomy, but we're going to walk through it first. In terms of muscles, there are a lot of muscles in the forearm, tons of things going on, but on the lateral epicondyle, this is the origin for the extensor and supinator tendons. So they all originate from the lateral epicondyle, whereas on the medial side, these are the origins of the flexor and pronator tendons and muscles. So essentially we kind of call them flexor pronator masses or supinator masses, whatever. They kind of all just coalesce onto those epicondyles. And from a nerve perspective, there's a bunch of nerves that run by there. There's obviously really small branches, but the ulnar, radial, and medial nerve all run around the elbow. So pretty much all the big three nerves are running around there. And if we're taking a look at this here in terms of anatomy, here you can see this is the end of the humerus, and we have the medial and lateral epicondyles. These kind of bony portions, this is where those flexor or extender tendons are kind of coming off of here. So this is what we're looking at. From a tennis elbow perspective, you can kind of see here, this is going up to that lateral epicondyle. You can see these are those extensor tendons and muscles attaching right here on the lateral epicondyle. And that's where we can have injuries. And here's a little closer picture saying, hey, this is coming over these extensor tendons onto that. And then from a medial perspective, the medial epicondyle, you can see here, this is where our pronator and flexor mass originates and attaches right there. So not a whole lot is going on there in terms of things you definitively need to know in terms of the names of all of them. There are specific names for each one, and there's a bunch of different muscles, but just understanding grossly that, hey, the flexors and pronators are coming from the medial epicondyle and the extensors and supinators coming from the lateral epicondyle. We're going to be good there. Now, let's real quick just talk about the pathophysiology. As we talked about before, itis is kind of a misnomer, meaning epicondylitis, or, and we talked about it all the time with tendinitis. It's kind of outdated. There's probably a short term where, yes, it is inflammatory when something just starts up, but most of these are degenerative in nature. And so we've kind of moved from the itis to osis or tendinosis. And usually they're due to excessive use of the tendons. The most common reason we're having these is kind of overuse of the tendons. But as we've learned about in all of our tendinopathy lectures we've talked about previously, is that it's no longer this itis or acute inflammation. It's usually this kind of degenerative type changes or this tendinosis. And from an epidemiologic perspective, this is about 1 to 3% of the population will get tennis elbow at some point. And between the two, lateral is way more common than medial. So if you get, a complaint of an epicondylopathy, 90% of the time it's lateral, whereas medial 10%. So you will see both of these. I see lateral way more than I see medial, but I've seen both, and the data does show that it's much more common lateral than medial. From a risk factor perspective, let's talk about that. There's a couple different things. For both of these, it's going to be lots of gripping, things like manual labor. A lot of times on question stems or whatnot, they'll talk about someone who, works in construction, is using a hammer or turning some sort of like wrench or something like that. That's like the background they give. But we're thinking about a lot of gripping. That doesn't necessarily have to mean person who does manual labor. There's lots of people who weightlift and have lots of gripping there, so that can impact that as well. But for both sides, medial and lateral, lots of gripping, manual labor, those seem to be risk factors. And then from a lateral perspective, usually it's repetitive motions in either wrist extension or supination. And then medial, it's going to be repetitive motion to wrist flexion or pronation. So that kind of makes sense when we think about the anatomy, right? we're having lots and lots of extension and supination. That's going to really put stress on the tendons that are attaching to that lateral epicondyle, and vice versa. On the medial side, if we have repetitive flexion and pronation, then that's going to lead to issues of the medial epicondyle. And if you think about like tennis, right? Tennis doing a backhand, when we're doing a backhand, that's essentially extending our wrist and supinating. So kind of that's what we think about. And whereas golfer's elbow is medial side, we're doing this kind of flexion and pronation of the wrist. And so that's why they call them tennis and golfer elbow. So those can be risk factors for them. It's not necessarily that easy, and that plenty of people who play tennis can get medial and the other way around. But that's why they say that, because it kind of makes sense from a mechanistic perspective. From a presentation perspective, usually this is insidious in onset, right? There's usually some spike in activity. If there's one common thing we've talked about with tendons is that usually there's some underlying mismatch of load, right? Someone just did something more, you've kind of increased their activity or done something that's usually part of the background. And this does act like other tendon injuries in terms of, hey, sometimes it hurts to start, can be better when we loosen up a little bit, but then worse again, either at the end of the activity or the next day. And then they'll complain of pain over the lateral or medial epicondyle, or just a little distant to it sometimes. It should be relatively well localized though. If it's radiating, you may think about having a nerve involved, but once again, it's going to be insidious in onset, usually some sort of spike in activity, and localized to either that medial or lateral epicondyle. From a physical exam perspective, here we're going to have a couple things that we'll have in common. So both of these could have pain with a handshake. So essentially, if you just like shake someone's hand, a lot of times they do that. That's one thing I always try to remember not to do is when I know someone's coming with an elbow complaint, I try not to shake their hand because sometimes it really hurts. And we're just so ingrained as a culture that it's disrespectful to not shake someone's hand. But I try not to even do that just to make sure it doesn't hurt. But these people may have pain with a handshake, either on medial or lateral. That works. And a lot of times if you are gripping their hand, if they're close to their side, right, if they're close to their body, it doesn't hurt as much. Where if you bring out that arm further into extension, that elbow into extension, that may kind of create more stress on the elbow, and that can be harder for them, so it may hurt. From a lateral epicondyle perspective, we're going to have tenderness palpation at the lateral epicondyle, and you might have pain with either resisted third digit extension, or supination. So if you think about these patients, third digit extension, you have their hand on there, you're pushing down the third digit. That's what the ECRB, that's pretty much what that's responsible for, is that movement. That's what we're testing because that's the biggest one that contributes to the lateral epicondylopathy. Wrist extension, so bringing the wrist up and just pressuring against extension, and then supination, you're trying to create resisted supination. That's what we're doing for the lateral, and those ones should be positive if we're looking for lateral epicondylopathy. From a medial perspective, we're going to have tenderness palpation at that medial epicondyle, and then pain with resisted flexion or pronation. So once again, wrist flexion, bring it up into flexion, or pronation, just resisting those things. And essentially, those are kind of the big tests that we do for these tests. So from medial or lateral, it's going to localize depending on what movements they resist. So once again, lateral, maybe resisted third digit extension pain with wrist extension or supination. Whereas on the medial side, for medial epicondylopathy, it's going to be tenderness palpation at that medial epicondyle, pain with resisted wrist flexion or pronation. So those are kind of the big things to think about there. And next, let's talk about imaging and diagnosis. This is a clinical diagnosis. You do not need imaging to make this diagnosis. Quite honestly, I don't know if I've ever made the diagnosis based off of imaging. Usually it's all clinical, and we'll talk about imaging, but this is not something you have to get imaging for. In primary care, a lot of times we think we want to get x-rays first, like, oh, let's get x-rays. X-rays are really not that helpful unless we're looking for some sort of calcific tendinopathy, which is not very common there. We don't really necessarily need to get x-rays. So this is one where I have no problem if someone's referred to me and doesn't have any imaging of the elbow in terms of like an x-ray, because I don't know if it adds that much. Maybe I'll get it if we're concerned for other things, but that's usually not my requirement at all that someone needs to get those. Ultrasound is a good imaging modality if you have the ability to do that. You may see thickening of the tendon, maybe the anechoic kind of black regions on ultrasound, or increased vascularity, meaning increased blood flow, all signs that is just kind of pointing towards a tendinopathy. And a good option if you have it, but not everybody has it, and I get that. But usually we don't need any of those, and we just kind of diagnose it and move on from there. But there are times where maybe we get an MRI if things just aren't healing, right? If you're treating things appropriately and they're not getting better, that's something we can consider to get an MRI or an EMG or nerve conduction study test. Because sometimes if someone's not responding well, could this be a nerve entrapment? And so just something to think about from that perspective. And then going into differential, this is really important. On the lateral side, we think about radial nerve pathology. The radial nerve kind of tracks on the lateral side of the forearm. And so we're kind of thinking, hey, could this be a nerve issue? The radial collateral ligament on the outside, that could be one. And there's also something called osteochondritis dissecans. Usually it's in our younger patients, which is kind of a issue of the bone and cartilage underneath it. Those are all things that could be happening on the lateral side. And then medial, we think about ulnar nerve pathology, or the UCL, or the ulnar collateral ligament, which is kind of like the Tommy John ligament. All those can happen there. The kind of number one takeaway I would say is if we're treating this though, and it's not getting better, consider nerve stuff on your differential. That is the one thing to think about. If we're treating it really good and then it's not getting any better, we have to think about, hey, could there be a nerve entrapment somewhere? And that's kind of what we see a lot of times is refractory cases tend to be more nerve related. And so we've talked about differential here. How do we actually treat this? Well, treatment is pretty similar to lots of other tendon things, but we have lots of options. The good news is we have a watch and wait approach, which means some data indicates that at 12 months, like if you do nothing, most cases will return back to baseline. And that's not necessarily like the best thing for people because, it doesn't feel good in the meantime. But if you did nothing, there's a really good chance, for some people that you could be just fine. And so that's like something to know, like, hey, if I just like ignore this, it might get better. It may get better. I see the people who don't get better. That's part of my job. But if you're in primary care saying like, hey, you have this, you can give them an option of like, hey, let's just wait it out. That's totally fine. But a lot of times it's not necessarily going to be there. And the reason why it's not necessarily the best choice too is because, we say, at 12 months it's no outcome. But what if they've had pain for like 9 months and we could have shortened that down? So it's real pain. Patients are experiencing real pain. So I don't think we should just dismiss them saying, it'll be fine at 12 months, same outcomes. Well, no, what about the 9 months of things they, couldn't do? And so I'm not saying that as a don't do anything. I'm just saying that, hey, we have lots of modalities to treat this. And even if we don't do anything long-term wise, probably going to be okay. But everyone's different. Not everyone gets better at 12 months. So first line for this is going to be physical therapy. As I mentioned many times before, tendons like load. And it's that right amount of load, right? Not too little, not too much. And so getting into therapy is really good. The literature's kind of shown you can have a mixture of different contraction types, working on isometric strength, then eccentric or heavy slow resistance. And there's pretty good outcomes with this. But once again, the idea is that we're just progressively loading, right? So giving you the load that you need at the right time and then progressing you so you can handle more. That's usually what we prescribe first. And other conservative things we can do are the counterforce straps, which are the straps that go around your forearm there to kind of take pressure off. What that's doing is that's dispersing the force from just one spot on that epicondyle to kind of a more broad base where the strap pushes into the muscles. So that's what we're thinking about. Also, you can do wrist braces like at the actual wrist to prevent like extension flexion of the wrist to kind of just keep things calmed down a little bit. And those are okay and can be used judiciously in conjunction with therapy. These are not long-term options, right? Because they're not treating the underlying problem, but they're just kind of calming things down. And there's always a time and place for calming things down, right? So this might be, hey, you're super angry, you're flared up. Let's get you into a wrist brace just to calm things down for like a week. And then after that, we can kind of slowly reintroduce things, get you stronger again. So there's definitely a time and place, but it's not just, hey, here's a wrist brace, you're good. Because then it's like, okay, how long do I wear this for? Like, do I never use my wrist again? So that's not a good long-term answer, but definitely something we can think about to kind of calm things down. That's usually how I treat any sort of splinting, just to kind of calm it down in the least amount of time that we need to do it. And from an injections perspective, there are lots of injections. The one thing I'm going to drive home is like, please don't inject steroids into this. And I'll get patients who they've had it done before and they're like, man, this worked great. And now it's back again. And yeah, that's exactly the point. Like it's back again because we didn't get to the underlying problem. So as we know, steroids are pretty darn good at improving pain. And the data shows that it is good. It's really good for short-term pain improvement, but long-term wise, doesn't seem to be any better than if we didn't do anything. So once again, I'm always judicious on the use of steroids. Will I ever inject someone into a tendon with the steroids? Probably not on my own choosing. It'd have to be a really good conversation with them to say, hey, they understand the risks and benefits. But for this, it's really just short-term and nothing long-term is going to be good. So I would not recommend steroids there. Understanding there's life and stuff gets in the way and some people need to have pain gone for one reason or another. I get that. But overall, not the best strategy to inject steroid into tendons. There are also other injections like prolotherapy, where we can do prolotherapy plus a tenotomy, kind of make the area a little angry. That helps with analgesia. And then PRP, which is actually one of the decent use cases of PRP. It seems to be lateral epicondylopathy. However, the point I want to make is that none of these are really fixing the underlying problem, right? So like anything we inject isn't like magically making things go away or get better. It seems to be a way of kind of help modulating pain or decreasing our pain so that we can tolerate more. That's generally what it goes down to, because we know that the model for tendon change is that tendons like load. And so we need to load it up. And if we're just doing injection but not loading it, then it may kind of bring down the pain for a little bit, but it's not fixing the underlying problem. So that's just something we think about. And then last case is going to be surgery. For this procedure, usually it's some sort of either tendon debridement and or release. That's really not a common one. I think most people, when they're getting to that point, I think most surgeons aren't going to recommend that either. So we're not trying to get any sort of surgical treatment for epicondylopathy. That is just not where we're going. But overall, responds pretty darn well to conservative treatments, and we have lots of different modalities that may work for that. And so in summary here, lateral epicondylopathy is the most common type. They are insidious in onset and usually related to some sort of spike in activity, right? The pain is usually located to one of the epicondyle areas of the elbow, medial or lateral, depending on where the pain is. For lateral, pain is going to be worse with the resisted extension, supination, and third digit extension. For medial, pain is going to be worse with the resisted flexion and pronation. And then we're treating conservatively, right, to start. Most of these heal fine with just conservative therapies. Then we can try injections if we need to, and surgery being our last case resort, right? We're never trying to get to surgery, but most of these things heal really well with that. And this concludes the podcast. Thanks so much for stopping by. I really appreciate it. I hope you found today's episode helpful. And if you did, it would mean the world to me if you left a 5-star review on your podcast platform of choice, or if you share it with a friend who you think might enjoy it. And if you never want to miss a piece of content, consider signing up for my mailing list, which is linked in the description below. I'll send out the content I release during the week and promise to never spam you because I hate spam just as much as you. Now, that's it for today. Get off your phone, go be active, and have a great rest of your day. We'll see you.